Barrett's esophagus is an important precursor lesion for esophageal adenocarcinoma, a cancer with rapidly increasing incidence throughout the Western world. Currently, dysplasia is our best marker for neoplasia developing in Barrett's esophagus. High-grade dysplasia is associated with a markedly increased risk of developing cancer, at up to 30% at 5 years. It is also associated with 40% for prevalent cancer at the time of diagnosis. High-grade dysplasia is still a curable lesion. Current ACG professional recommendations state that the finding of high-grade dysplasia in flat mucosa should be confirmed by an expert GI pathologist and a subsequent endoscopy be repeated within 3 months with an intense biopsy protocol. Recent guidelines also suggest that high-grade dysplasia with mucosal irregularity should undergo endoscopic mucosal resection, and that when high-grade dysplasia is confirmed, even when unifocal, management options that should be discussed with the patient include intensive surveillance, esophagectomy, or ablative therapy. However, esophagectomy is no longer mandatory for high-grade dysplasia. There are a number of unresolved dilemmas regarding the management of Barrett's esophagus with high-grade dysplasia. One of them involves the surveillance protocol. The biopsy protocol for Barrett's esophagus surveillance includes 4-quadrant biopsies every 1 to 2 centimeters with more intensive sampling of any mucosal abnormalities. This may fail to detect occult adenocarcinoma as only a small area of the mucosa at risk is being sampled. Therefore, a more intense biopsy protocol has been suggested by the Seattle group, especially for high-grade dysplasia. This includes 4-quadrant biopsies with jumbo forceps every 1 centimeter. This protocol has not been validated outside of Seattle and has not been tested in a resection-based study. Our study aim was to perform a resection-based study on specimens from patients with Barrett's esophagus complicated with high-grade dysplasia and look for cancers missed by the Seattle protocol and by a less intense biopsy protocol. We thought that a resection-based study would be the best way to validate an endoscopic surveillance protocol. This resection-based comparison was not performed previously in the original work by the Seattle group. Our large volume referral center was ideal for this purpose. Study design. We performed a retrospective cross-sectional study of patients with Barrett's esophagus and high-grade dysplasia who underwent esophagectomy for the indication of high-grade dysplasia between 1999 to 2006. Our data source was an IRB-approved database of patients undergoing esophagectomy for superficial esophageal cancers. We identified those with high-grade dysplasia. We also excluded patients with obvious tumor, nodules larger than 1 centimeter, frank ulceration, or strictures. We also excluded patients whose worst pre-op diagnosis was low-grade dysplasia or intramucosal carcinoma. At the Cleveland Clinic, there is no uniform agreement between endoscopists regarding the surveillance biopsy protocol for Barrett's esophagus. Therefore, pre-surgical endoscopic reports were classified according to the biopsy protocol for each patient as either the intense biopsy protocol per Seattle group, 4-quadrant biopsies every 1 centimeter done with the jumbo forceps, versus a so-called clinical protocol that included 4-quadrant biopsies every 2 centimeters. In both protocols, any mucosal abnormalities were sampled. 2 GI pathologists who are known as experts in the field re-reviewed preoperative biopsy specimen and the surgical specimens. The study design had the advantage of being resection-based series over many years, but included eventually a relatively small number of cases and was cross-sectional without follow-up. Our results showed that among 204 patients that underwent esophagectomy for superficial cancer, 134 were eligible for the study. Among these patients, 20 had preoperative endoscopy with the Seattle protocol with worst diagnosis of high-grade dysplasia, whereas 13 had their preoperative endoscopy done with the clinical protocol with worst diagnosis of high-grade dysplasia. Unsuspected cancers at surgery were found at 8 out of 20, that is 40% of the Seattle group, and in 4 out of 13, 30% of the clinical protocol group. No significant difference between the two groups. The majority of patients with unsuspected cancer had mucosal abnormalities at preoperative endoscopy, and in addition, multifocal high-grade dysplasia was prevalent in these patients. As non-invasive approaches to Barrett's esophagus with high-grade dysplasia are becoming more and more popular, this population of patients may no longer undergo surgery at all, even those that are young and good candidates. As such, we feel that this study is unique in that it is resection-based and reveals high rates of missed cancers. It actually may be the last study of its kind for patients with Barrett's esophagus and high-grade dysplasia. The ideal management for Barrett's esophagus and high-grade dysplasia is still debated and depends on the local capabilities of each medical center. We put into question the continued endoscopic surveillance approach that is still acceptable in professional guidelines and in some medical centers. As new advanced endoscopic surveillance approaches are emerging, a relevant study to judge the reliability of these approaches would be a resection-based study that involves preoperative advanced endoscopic approaches such as chromoendoscopy, narrowband imaging, high-definition white light endoscopy, and endomicroscopy.